Good afternoon, everyone. My case is papillophlebitis in a hypertensive diabetic patient, an atypical presentation with diagnostic challenges. Introduction: papillophlebitis is a rare idiopathic condition affecting the central retinal vein in young and middle-aged adults. It is characterized by optic disc edema, venous dilatation, and tortuosity, resembling CR vivo. Etiopathogenesis is unclear, but it is postulated to be an inflammatory or ischemic event affecting the retinal circulation. It differs from CR vivo by its mild to moderate visual impairment and lack of systemic thrombotic associations. Common risk factors include systemic hypertension, diabetes mellitus, hypercoagulable states, and vasculitis. This condition is usually self-limiting, but long-term follow-up is essential to monitor for complications. Case summary: a 57-year-old female came with complaints of defective vision in left eye for past 1 month. Past history: patient is a known case of systemic hypertension and type 2 diabetes mellitus for past 8 years on oral medication. Cataract surgery done in both eyes 6 months ago. Visual acuity in right eye is 6.9 partial, improving to 6.6. In left eye it is 6.24 partial, nil improvement with pinhole. Anterior segment examination of both eyes shows normal. Fundus examination: right eye media is clear, disc is normal, cup disc ratio 0.3:1, vessels shows arterial attenuation and AV crossing changes. AV ratio 1:3, macula is dull, FR is absent, in background cortical spots is present. In left eye media is clear, disc edema is present, cup disc ratio is not made out, venous dilatation and tortuosity is present, AV ratio is 2:4, macula shows edema, FR is absent. This is the fundus picture of the patient. In left eye, there will be optic disc edema with tortuous and dilatation of vessels is seen. OCT of left eye shows cystoid macular edema with CMT 16 microns. My diagnosis is right eye grade 3 hypertensive retinopathy, left eye papillophlebitis with cystoid macular edema. Management: since papillophlebitis is self-limiting, treatment is mostly supportive. Most cases resolve spontaneously over months with good visual recovery. Systemic workup for hypercoagulability, vasculitis, infections, or autoimmune disorders to rule out risk factors. In case of macular edema, for mild cases, observation is enough. In case of persistent edema, intravitreal anti-VEGF should be considered. Anticoagulation is not routinely required unless systemic thrombophilia is confirmed. Clinical implication: papillophlebitis should be considered in cases of optic disc edema with venous congestion, especially in middle-aged patients. Differentiating from CR vivo is crucial as management and prognosis differ. A thorough systemic evaluation for underlying vascular and inflammatory condition is recommended. Close monitoring is needed to assess spontaneous resolution and prevent long-term complications like macular edema. Take-home message: papillophlebitis is a rare but important differential diagnosis of optic disc edema. It may be misdiagnosed as CR vivo. Careful clinical evaluation is the key. The condition is generally self-limiting, but systemic association should be investigated. Regular follow-up is essential to detect any complications early. Thank you.
Thank you very much, Dr. Amendra. Any question for you?
You said it's a phlebitis, then why didn't you give steroids in this patient? That diagnosis itself says it's a phlebitis.
Yes, sir.
So why don't you give steroids in this kind of
Yes,
patients?
sir, we can give steroids.
So what is the indication for giving steroids?
Cystoid macular edema is an indication.
Is it different from neuroretinitis? If I say it's neuroretinitis, optic disc edema and vasculitis, it's neuroretinitis.
Yes, sir. In pupil, relative afferent pupillary defect will be absent in case of papillophlebitis.
Neuroretinitis, it will be absent, RAPD. Yeah, because neuroretinitis is the disease of, and you won't see so many hemorrhages in neuroretinitis.
Yes.